This week on the BackTable Podcast.
We used to have to wait to use this really exciting drug until things got really bad, until your cancer came back or it moved around your body. And now I have an opportunity to contribute to your care earlier when I think we can make a big difference. And so I just start framing it like that so that everyone understands that surgery is still a part of this. It is still the cornerstone of this care. I am here contributing and adding on. This is an escalation therapy. This is an add-on to what the standard of care is so that we can get better outcomes for them. And I very much agree with Mihir. People are savvy. The marketing campaigns around the use of this drug in a variety of different disease states has led to common knowledge of it. And so you can build upon what the patients are bringing into the clinic and say, now we get to do that for you.
All right. Well, welcome everyone to BackTable Podcast. This is a great opportunity for us as clinicians to share some thoughts and to visit about changes in our field. And we are really excited today to come together, 4 clinicians here, wanting to share and talk in a second of 2 episodes on the new indication for neoadjuvant and adjuvant immunotherapy in head and neck cancer. A recent trial published 689 in the New England Journal of Medicine. And we're here to talk about its practical implications and how we see it kind of at the bedside. And so let's start off first with some introductions. So why don't we start in my left upper corner here. Mihir, why don't you introduce yourself?
Happy to. Thanks for having me, Adam. Mihir Patel. I'm a head and neck surgeon at UNC Chapel Hill Lineberger Comprehensive Cancer Center and co-lead of the head and neck program with Sid.
Good deal, Mihir. Sid, why don't you go ahead?
Yeah, Adam, thanks for doing this. And I'm Sid Sheth, a head and neck medical oncologist at UNC, and I'm co-lead of the head and neck cancer program with Mihir.
Awesome. And one of my favorite people in all the world, Dr. Johnson. Jen, why don't you go ahead?
Hi, guys. I'm Jen Johnson. I'm a professor of medical oncology and otolaryngology at the Sidney Kimmel Comprehensive Cancer Center, where I help to run the head and neck cancer program as well as the precision oncology program.
Mihir, Sid, Jen, thank you for introducing yourselves. I'm Adam Luginbuhl, one of the head and neck surgical oncologists here at Thomas Jefferson University, and one of the principal investigators, sub-investigators for the 689 trial at our institution. And we're thrilled to be here today together. I would say that for the following podcast here, this is unsponsored. This generously provided as platform as clinicians to talk about our world as clinicians. None of us here have any relevant disclosures that would impact our counsel or thoughts that we share going forward. It's with some intent that we came here today with basically the duo team of medical oncology surgeon combo. As we look at paradigm shifts in our world, I think a lot of times we are seeing more and more of a team-based approach, and it's great to have cross specialties working together. So hopefully, if nothing else, you all walk away from this with that this is essential to implementation. The second thing I'd like to encourage from the first podcast. So our first, we had Dr. Ravi Upalari, Dr. Dylan Roden, myself on the first episode. We really encouraged, if you're a medical student or a resident or you're a director of these and at your institution, just encourage you all to take the paper and review it together as a journal club. Today, our goal is not to dissect the paper. We're not going to go through it with a fine-tooth comb. Our goal really is real-world application, but don't want to miss that opportunity to go through the data, understand it, and understand its implications. So with that, in summary, also our episode 1, we did spend some time on presenting the actual trial, presenting the dosing scheme, the neoadjuvant part, the adjuvant part. We presented also some practical implications of rolling it out as surgeons. We didn't have the medical oncologist on that, but we'll have some of that today. And then finally, we went over a couple cases as examples. So today, I'd like to kind of just jump right in. And on the first part is really the conversation, opening this up to a patient and talking about it. Mihir, as a co-surgeon, you and I often are the people that see these patients in our clinic first. And we're looking at, a stage 3, stage 4 patient with HPV negative disease. So just to remind ourselves who we're treating. And they're sitting in the chair in front of you and you're kind of thinking, shoot, this might be a sweet candidate to consider for this protocol. So how do you present it to them? What are the things you tell them or go through with them?
I mean, one of the things I mentioned is essentially that there's a new opportunity here for treatment, and most patients are pretty savvy in terms of what they know about immunotherapy. They've heard of the drug in many aspects because it's used in so many forms of cancer. And essentially, when I tell them or share, like, look, there's an opportunity to help your own immune system fight these cancer cells in a way that surgery can't do that, then they're often like, okay, that makes sense. And I say, I essentially tell them it's going to be a partnership and that we're going to work together. And given where we operate, most patients they're not really looking forward to having some part of their head or neck operated on in the first place. But so it's not a difficult thing to explain or to even, I wouldn't even say I have to convince them of it. They are very receptive to the idea of getting some form of immunotherapy, especially when you explain it in that regards.
Yeah, for sure. And maybe just in transition here to our medical oncology, Jen or Sid, why don't you tell me a little bit about what your thoughts are about how you present what the objectives are? So Mihir, I appreciate you kind of talked about the immune system as a whole, but tell us how you explain to the patient what you hope this immunotherapy to do as it relates to their cancer. Maybe Jen, take the lead on that. And then.
Sure. So I think for me, I see this as an evolution of the use of immunotherapy within head and neck cancer care. And I think something struck me when I was listening to the first episode of this podcast, and you said how excited you were to be in the row with your colleagues listening to this data be presented for the first time and how transformative it was. And as a medical oncologist, I got to do that twice before. I got to hear Checkmate 141. I got to hear Keynote 048 and have this thrill of a new way of contributing to the care of my patients. And now I get that thrill again. And when I present that to a patient, a lot of times I borrow from that excitement to talk to them and say, we used to have to wait to use this really exciting drug until things got really bad, until your cancer came back or it moved around your body. And now I have an opportunity to contribute to your care earlier, when I think we can make a big difference. And so I just start framing it like that so that everyone understands that surgery is still a part of this. It is still the cornerstone of this care. I am here contributing and adding on. This is an escalation therapy. This is an add-on to what the standard of care is so that we can get better outcomes for them. And I very much agree with Mihir. Like, people are savvy. The marketing campaigns around the use of this drug in a variety of different disease states has led to common knowledge of it. And so you can build upon what the patients are bringing into the clinic and say, now we get to do that for you.
I want to pick up on something you said there, Jen, and any one of you can answer on this one. And what do you mean when you say it's an escalation of therapy? I've heard people say, is this something that we're going to use to maybe avoid other treatments, or is its intent to reduce the tumor burden so the surgery is easier? How do you respond to a colleague that might have asked you, like, what your goals are with this therapy?
This is honestly, I phrase it as escalation of therapy because we are adding on to an existing paradigm. We are not supplanting it. We are not there to necessarily at this time change that there is a surgical plan, change what the surgical plan is. We're a little bit changing when it happens because you got to give me a second to get a couple doses in there at a time when we think that it will be most efficacious for you, when the tumor is still intact, when the tumor bed and the lymph node drainage is still intact and your immune system is ready to receive the information that we're going to try and convince it of. But we are not there to change things so much that you aren't going to the operating room, that you aren't going to be talking to somebody about risk-adjusted adjuvant therapy. It's just now we also use immunotherapy within that treatment.
To add to Jen's point, this is a escalation not only therapeutically, but also logistically. So we are asking patients to come in to receive treatment prior to surgery, which they did not have to do before, but also receive additional therapy after their surgery, whether that's in the adjuvant setting with chemoradiation therapy or with radiation therapy alone, and then adding additional therapy on the very back end with pembrolizumab alone. So this is truly an escalation because patients are having to come back to see all of us for a longer period of time.
It's interesting. I was going to say, just to add in, well, I think of the word as escalation is getting heightened concern, or, you're taking it to, I almost think of this more along the lines, I think of things, I use these analogies, but I almost think of this is a recipe with ingredients. And once you start adding in the salt, the food just starts tasting better and you're seasoning it just right. And I think immunotherapy is just a part of the recipe that is just making things work better, not necessarily in escalation because we're the number of modalities or the number of treatments, because the toxicities also are very different compared to various, let's call them traditional forms of chemotherapy. And so in getting back a little bit, to what Jen had mentioned earlier, I mean, as we continue to get smarter with biomarkers and various forms of treatment, there might be a day when our jobs are a little bit on the line.
Yeah, for sure. And I look forward to that day with absolute expectation. So all you scientists out there that are grinding away and writing your grants and giving us good feedback on these patients, kudos to you. And students and residents that are working in their labs, again, a shout out to your work, because shoot, if we can't get to a place where we have better understanding of who's going to respond, man, that's the podcast I continue to look forward to as well. And we'll get there. I'm confident in it. Along those lines, right, if we're going to add toxicity, if we're going to add more ingredients to our soup, and we're going to do these things, there has to be an advantage for the patient. Maybe let's walk back just a second to that paper, the New England Journal of paper, the 689 paper. What in there do we tell our patients is the advantage? I think we have to start with that, really grasp that, and then we can translate that. Because it's wait a minute, we're going to talk about toxicity. But first, I think I want you guys to just express what is the added benefit.
There are two major advantages of implementation of Keynote 689 and giving to a patient. The first is pathologic response. And so we give a patient immune therapy up front. We may or may not see a dramatic clinical response. So when we image them after the 2 cycles of pembrolizumab, they may not see a huge change in their tumor. But what we're really hoping for is once our surgical colleagues get to the OR and take the tumor out, under the microscope, we're seeing a change in the tumor in a way that it's starting to die. And that is really important because it affects what we do in the postoperative setting. So, and we did see that with 689, that there was an increased rate of pathologic response compared to obviously no response with doing upfront surgery. The second benefit of this therapy is that we're seeing an improvement in event-free survival. And this is not the same as overall survival, but it does give us an early indication that patients may be living longer and benefiting from this therapy. And we await to see, does this really bore out if there's an overall survival benefit as well with this therapy? And that in due time, we'll see that result as well.
Yeah. Yeah. Nice. Now that we have okay, why is this a good thing? Let's talk about some of the things that we've seen. Mihir, Jen, maybe give us a real life example. Patient that you saw went on this, had a side effect. How did it affect their care? What type of toxicity are we talking about here? What does that mean?
I can give you an example of someone who had toxicity in the neoadjuvant space, because I think that that's really important to talk about here in terms of multidisciplinary care. We had an individual who lived at least 3 hours from our medical center and had been identified by one of our surgical colleagues as an excellent candidate for the 689 protocol. I agreed. I met with the patient by telemedicine and said, okay, I'm going to get you to a colleague of mine. They're going to give you this therapy. It was seamless. Right into their office, saw them expediently. I mean, it couldn't have been more than a week that we got them started on pembrolizumab, which I was very proud of. Got the first dose of pembrolizumab, no problem. Got the second dose of pembrolizumab, no problem. On their pre-admission testing, had a transaminitis that was a grade 3 autoimmune hepatitis, and that was how it was picked up. And suddenly we have a whole new aspect of coordination of care. Of course, there's the immediate management of that toxicity, but then there was expectation setting with the surgical team of, I know that you had an OR date, you had everything planned, but I'm going to need a minute. And then trying to communicate with a surgical colleague, like, I have a mitigation algorithm. I have a treatment algorithm for this, but I cannot tell you exactly how fast they're going to respond, when those LFTs are going to be down, how many steroids they're going to be on when their LFTs are within a normal range, and how we're going to get that person to the OR in a predictable way, because we're a little off script here. The patient wound up responding very, very quickly to a course of steroids. They were in the OR in 2 weeks, with near normalization of their LFTs. But that communication between a surgeon at our Center City campus, a med-onc who's not treating them at our Center City campus, a med-onc colleague who is 3 hours away, who is a generalist and absolutely fabulous and hanging on with all the things that we're doing, presents a whole extra level of logistical challenge. And while that is the exception, not the rule, we all have to be just a little flexible here and work with one another and communicate when those types of things happen. The rate of grade 3 AEs with autoimmune toxicity in total for the trial was only 10%. That's not zero.
Yeah. Yeah. And it's interesting. I've had just my own experience. I've had working with some colleagues, and we had a similar event happen, and immediately they're like, whoa. We're done with this. We're folding in. We're putting this on the shelf. Like, can't handle that. And I think if as we walk into this together as a community of care providers, we mustn't forget the data that shows that there is something going on here, profound, remarkable, and helpful for our patient population. But we don't get it without some concern, and we have to be able to navigate that. Be honest with our patients about what they face, but also ourselves be understanding of those moments. They come, that patient shows up, and just, I don't know, cautionary tale about being reactionary to some of these things, as we often are, right? Because we're so passionate about our care. We never would want to see a patient who could have been just fine and now is not. Well, if we look at our population of patients we care for, what about the additional 15 to 20% or 10% or 5%, depending on the CPS score, of improvement we get in that population? So anyways, Mihir, any thoughts about risks or examples you have or thoughts you want to share as a surgeon as it relates to this? Because I think there is a little bit different understanding from a surgeon's mind as it relates to risk, like what we're willing to tolerate. I mean, we'll tolerate a fistula any day of the week because we know how to fix that. But transaminase, I didn't even pronounce it. I'm like losing my mind. What do you mean the liver is in trouble?
Yeah, no, I think the point is, when you think about operationalizing things, you're only as good as your failure. And whatever in your system is prone to failure is going to a little bit define how you work. And the other thing, as you mentioned, is we often as physicians tend to remember those emotional reactions we have to certain things, but those decisions don't really guide objective data. And so we also have to take a step back and look and say, oh, the data is actually more favorable for more people, even though I had this one traumatizing event in my own mind, when you talk about how to deal with these various systemic complications that can happen. But the point is I think moving forward, Jen's made me realize that we have to be extremely thoughtful on that communication, not just the communication, but having a fail-safe for those patients when that happens, even potentially having an open OR day ready in the next week or two, things of that nature, which are going to be a little amorphous because you don't know when the values are going to come down and when do you think about admission. And even if you're thinking about admission so that you can get them to the OR, what type of bed do they get? Because all of our centers are having issues with hospital capacity in many regards. So I think that you raise a wonderful point, Jen, about how to navigate that. And Adam, from our standpoint, the inpatient side or how to manage that moving forward will be something that will be an evolution.
So along those lines, I want to do one thing. I want to have you each, without a sentence format, just bullet point format, give me the top 2 things you think are going to be the biggest challenge for practical implementation of this into any program, whether it be a satellite academic institution or even in our community practices. Top 2 or 3 things that you think are going to be challenges that people will face. No sentences around it, just bullets. So Sid, we'll start with you, and they can be the same. They can overlap.
Changing mindsets and timing of when we're going to do all this and how to make it work in each individual practice and systems operation.
Okay, thank you. It's Jen.
I think I'm going to go back to something you talked about in the first episode, obtaining CPS and surgical timing.
Nice, Mihir.
I really think it's going to come down to, at least for me, the top two priorities: communication and access.
Yeah, for sure. And I'll refer our folks back to that. All these topics came up in the first podcast. And so not to be redundant, but I want listeners to hear that we here, and this really want to make sure we're clear that those challenges we just talked about have to be faced head on. It can't be, hey, let's give this a run. It's like, let's sit down as a group. Let's everybody get to the table. Let's have an evening, an afternoon where we really lay out how we're going to implement this. Nurses included, navigators, pathologists. We heard about CPS score. That's a requirement. So you have to get the CPS score. So we won't belabor that here, but just a reference back to that and a reiteration of these challenges. So I want to transition.
We just did that, and it requires all those folks. But we just had a meeting for that purpose specifically last week.
Yeah.
Nice.
And when you say get everyone together, you have to be really thoughtful about who everyone is. And I think you were starting to expand on it. Like here you've got medical oncology and otolaryngology, head and neck surgery represented, but it is nursing. It is your medical records team, what they should be going and grabbing for you. It is pathology, and it's not just pathology where you are, it's pathology from your referring sites. Because if they don't do in-house PD-L1 CPS testing, which most places won't, who are you partnering with to go and get that done? Where are you sending them out? Or are you relying on us to be able to do that? And someone should set that expectation. So it's pathology here, it's pathology there. It's medical oncology at your academic center. It's medical oncology at outlying centers where that poor person has just seen 3 iron deficiency anemias, 2 breast cancers, a lung cancer, prostate, and, oh no, head and neck. So, which admittedly is the way that some practitioners will see head and neck because it is not dominant in their volume, so they are less familiar with it. And our job is to make them more familiar.
And so I appreciate, Mihir, that your group got together. And I love how we've talked about an example of referring and our medical oncologist being engaged here. I'd like to transition a little bit to a specific example of what do we do with the progressor? Again, it's the unique scenario, but it is, back to Mihir, your point, we do, as surgeons, we might be more reactionary. I don't know, maybe it's just me. Maybe our med oncs are as well, but we see one case and we're like, my goodness, the sky's falling. So like, how do we manage that scenario where someone we know, we have a patient, I'm not talking about toxicity here, I'm talking about tumor progression. So you get them on and maybe it was a poor selection. We talked in the first episode about selection. We're not looking for people that are barely resectable. That's not this That's not this paradigm. We're looking for people that are advanced staged, that we're not using it as a modality to make the surgery maybe possible. So we've covered that. But let's say you have it. Let's take an example. You have a T2. It's going to be maybe a hemiglossectomy with multiple nodes in the neck. So you're stage 3 or 4. And you put them on it. First dose comes around and you've set up your paradigm so that the surgeon sees them before the second dose. We talked about it, doing that in the morning, getting the scan, morning visit at 10 a.m. and then the infusion at 1. So you have a stopgap to prevent the second infusion. And here, we'll start with you. You're the surgeon. Patient's in your office. It's maybe your patient, maybe a colleague. You're seeing them. They've gotten 1 dose. And that's no longer a T2. I mean, that's pushing. You're seeing a ramp up of tumor volume. Patients like, my pain is increasing. Clearly, every sign is showing you that it's on the move. What do you do?
So my reaction is to want to just say that we're going to the operating room. My response is, let's have a conversation about this with, I'd call Sid up and we'd look at probably the scans together, look at, various things, because intermittently we're getting scans right before surgery. So it is something that we would probably look at on a case-by-case basis. And this is where I think the communication is important, because is there a possibility that, and I don't remember if you said it was in between the first and second dose or after, so is there a possibility that things could turn around, or is it just an inflammation factor? It's really tough to read, as we all know, on a PET because of the activity. So that's not necessarily going to give us an indication. So we're now, as you mentioned, relying on whatever clinical symptoms they're having. And that's where it does become a challenge. I think it would require just a more in-depth thought to it. But even to take it a step further is, what if that is creeping along the floor of mouth and now starting to involve bone? It also changes your reconstruction options, because are you prepared for reconstructing the jaw if you need to? And these are items and options that are difficult to quick pivot, especially when we're using customized plates. That's where it really gets tricky, I think. But in the tongue, it's, soft tissue reconstruction is going to be a little bit more versatile. However, that would be the way I would go about it, is actually having a conversation with Sid and saying, am I being reactionary, or are we going to open up a space and be more responsive about this? And especially given the data overall, this is what I was talking about before. You have these anecdotal things where you react to it, but what we really need to do is work on how we respond to things. And that's, I can't take credit for that, but it's something that we just really need to be mindful of.
Yeah, let's walk right into it. So Sid, he calls you up, you got this case, and he's just given some sage counsel about how, don't react here, Sid, I want you to respond, which I love that thought. What are the things we could do? Outline, okay, obviously the patient's not in front of us, but let's assume there's obviously concern. What are some things we could do as a team?
Yeah, so the first response is always calm down, surgeon. And then the second is...
Whoa. All right.
No, but the main point, and why this is so challenging, as Mihir appropriately brought up, is this true progression or not? And so, one phenomena that we do see with immunotherapy is pseudoprogression. And what we've learned in not only head and neck cancer, but across oncology, is that if you're failing or stopping immunotherapy too quickly, you might be actually losing a therapeutic response opportunity. And so it's not only a conversation with the providers, but also bringing in radiology, neuroradiology, or head and neck radiologist to say, what do we think about the imaging? And even in 2025, our imaging modalities are imperfect, but at least we can get a glimpse of maybe what we think is happening inside the tumor. So I think that's number one. The second is, it's not only a conversation amongst ourselves, but having the patient there too, and making sure that they're understanding what we're seeing.
So Sid, I'm going to push you a little bit. All things are pointing to, this is not pseudoprogression. This is progression.
Okay.
Let's just, all right. I want to push you, what are we going to do to pivot, and how are we going to manage this scenario?
So then in this situation, I think we have two options. One is we go straight to surgery. The other is, can we escalate the therapy further? If we are really concerned about a time frame to get the patient to the OR, can we add something like chemotherapy that might help with cytoreduction? And so that could be another option to buy time and then eventually move the patient on to surgery.
Yeah. Jen, thoughts?
I would agree. Once you have somebody who you're worried that they are clinically progressing, and that can be picked up in that surgical visit. It can also be picked up for a medical oncology visit. I had a patient recently who came in and I said, okay, let's see how everything's going in there. Open up. And I was like, I'm sorry, that trismus is new. Absolutely not. Immediate phone call to the surgeon. I'm the one who needed to be told to calm down. I was like, that is not the way that you looked the last time I saw you, my dear. Something is going on clinically that this is not okay. So whoever raises the red flag, that should then precipitate a phone call between the two groups where you say, all right, this is what we've observed. We think that this is bad biology of disease that requires further escalation. We're worried that a surgical window is closing. How do we want to respond as a group? And then you are left with those conversations about further escalation with chemotherapy, or do you take them immediately to the operating room? And I bring up the idea of bad biology because no one on a multidisciplinary team wants to see someone go through a grueling surgery and on their first post-op assessments have metastatic spread, because that bad biology was there and it was trying to warn you from the beginning that that's what was going to happen. And I think that that's sort of the story that Dr. Roden or Dylan had talked about in the first episode, where when there is bad biology, you can try and get ahead of it as much as you want, but sometimes you can't. Mm-hmm.
I mean, I think it would be really wonderful if there was a liquid biopsy we could do partially in the way of that timing. Does that liquid biopsy correlate with the clinical symptoms? And then maybe even give us some information about that biology. Because in some sense, there are some patients who might say, I'm not sure I want to have 70, 90% of my tongue removed in this case, and I'd like to think about other options for my quality of life. And these would be wonderful conversations to have information on, so that we could be given better guidance, or at least help them understand what's going on with them a little more, so that they can make the decision that really aligns with their values.
Yeah. We covered so many things just in that 5 minutes there, talking about this one patient, communication, patient's values and importance of their input, discussion about whether to the OR, to get chemotherapy. All these things are not written out in the 689 trial write-up, right? This is real world. This is the patients in front of you. So I think that's the value of this conversation. It's really seeing what we can do and know that we do have things we can do, from patient discussion to pivoting to giving cytoreductive therapy. But just know that as you enter into this, you have to be anticipating this. You have to be okay with this concept that this may occur, and then be ready to know how to respond to it, opposed to react to it. I really appreciate that thought, Mihir. Any other thoughts on this one patient? I know we could spend a lot of time on it, but I did want to transition. But any other final thoughts on that? And I know, just to be clear, 689 did not have a chemotherapy avenue or part to it, but that is the reality of what we have done. I think every one of us on the screen have had a patient where we pivoted and said, hey, let's add chemo. And we've been able to calm the tumor down, get it to a place where it's actually not running out of control, and then brought them to the operating room after that therapy. My mentor for fellowship, Jim Netterville, would often say, prior to the immunotherapy era, but using chemotherapy sometimes for patients that are out of control, their tumors are out of control, to get some semblance of whether you're actually going to get even a chance at cure. And you give them a dose or two, see how they respond. And I know that, but there's some wisdom there in that thought process. I certainly appreciate it. Let's transition to kind of the last two sections here, and that is about the adjuvant arm. We haven't spent a ton of time talking about the adjuvant arm. It is important that we not forget that is part of this trial. We can love it, we can hate it, all the things. It's irrelevant right now. I think the important thing is that was what was written for. And so any considerations you all want to have about that, and we don't have to spend a ton of time here, but just to reiterate it as we look at a publication and how the trial was constructed, thoughts about that part of it.
I was going to say it might be worthwhile just to remind everyone what that looks like. And
yeah, I can quickly just remind folks from the trial standpoint, it was, I think, 17 doses total, 2 ahead of time. And then adjuvantly afterwards, it was 200 milligrams, Q3 weeks to complete the 17 doses. I think that brings you out to a full year. And I think the data we see in the graphs that show us there's an event-free survival, they got both of those things. And Jen, on occasion, will remind me about the Gore-Tex trial data that's come out and some of the importance of the adjuvant arm, and understanding that those are, if you're looking for the results you get in a paper, you can't ignore how they did it. You can't just say, well, it was the neoadjuvant arm, or maybe it was the adjuvant arm, or I don't know. But my point is I think it's important to talk about that, because there may be, I have heard a discussion say, well, we saw no pathologic response in the tumor, so therefore it didn't work, so therefore we shouldn't use it. In the adjuvant, we should stop. And I'm like, what? Wait a minute. Let's talk about that.
Yeah, and I think that you bring up a great point, because then, when you evaluate the tumor, you get the entire tumor to evaluate. You can look at the CPS score a little bit more meaningfully because you have the entire specimen. You have a little more data, on the specimen, the lymph nodes and things. But ultimately, the trial is the trial. I think you've got to follow it as best as you can. And that entire piece of it is what made it, the results, what they are. Now we're talking to getting back to our soup. It's like, well, I'm going to make gazpacho, but not put, I don't know, tomatoes in there, whatever. It's one of the things that I think you can't deny. And it's also one of the things that tremendously increases the complexity of how we deliver or even monitor adjuvant therapy in terms of compliance. Given that, let's say, at academic centers, you have patients that might be traveling at community centers. I think they're going to be better equipped to navigate the adjuvant setting for certain. And depending on how we partner or work together, I think, again, it comes back to that communication that we highlighted earlier. And also the access, are they getting in within 6 weeks for radiation? How do we coordinate the timing with radiation and medical oncology through that process? I think once they get through that initial setup, the rest of it probably falls into place. But I do feel like that our patients should follow the adjuvant setting in the way that it was prescribed, even though there's a lot of talk about, what that looks like and where the emphasis was. And even Jen brought up before, when the lymph nodes or the lymphatic system, it has not been tampered with, is an excellent time to give immunotherapy, which is what that pre-surgery part is. But in the afterwards, it's been impacted with surgery, and then it's slowly being further impacted with radiation. So nevertheless, that's a more philosophical thing that can be looked at later. But ultimately, bottom line is I do think that patients should be placed on the adjuvant therapy as prescribed or described.
Maybe Sid or Jen, in that aspect, have you seen toxicity increase over time, or once they get through the first or second or third dose and they've had no toxicity, they kind of roll through the year, or is there an additive effect?
We know with immune therapy, the toxicities can be idiosyncratic. And so unlike chemotherapy, where we can kind of have a better idea of you're going to get nausea or vomiting at this point, we can see something like autoimmune hepatitis at any point. And so I think our guard has to be up, especially now that our patients are getting exposed in the curative intent setting with immune therapy for longer periods of time.
I would agree that you do need to follow the protocol, because there must be an additional benefit to the adjuvant phase, because we see the benefit in some of our adjuvant immunotherapy trials. We have Gore-Tex-Nivo post-op trial. We have C-post. I know, cutaneous squamous, but we're seeing benefits in these squamous cell cancers in the adjuvant setting. So I very much agree with the neoadjuvant, but you've got to give the entire protocol if you're going to get the event-free survival that we're seeing here, and not hold that from people who don't demonstrate a pathologic effect, because we just don't know all of the different effects that we're having on this patient, both locally and distantly. As far as operationalizing, I think we spent so much more time talking about the upfront aspects of operationalizing this, because that's where we need to make a paradigm shift. After you take them to the operating room to refer to MED-ONC and RAD-ONC, there is already so much effort being placed there to get them to the chemo-BEMO doctors after you've taken them to the OR, that that's natural. You want to start RT within 6 weeks. That's not new to Keynote 689. That is a quality metric that we should be working on for all patients. And the addition of pembrolizumab through that. The only time where we might want to talk about a little operational difference is splitting the burden of care, like splitting the care so that perhaps the neoadjuvant's done at the university center and the adjuvant care is done elsewhere. And you better communicate that this patient was on that protocol so that they can continue that care elsewhere. I thought it was very heartening that we didn't see emergence of a new safety signal here. We weren't looking at new infield toxicities. And so therefore, the majority of us who are practicing are so familiar with managing immunotherapy that it's not terribly new in that setting. I do look forward to perhaps new subgroup analyses about, well, if you had this type of pathologic treatment effect or this type of pathologic treatment response, this is what to expect later on. And if that itself can become a predictive biomarker, but we need far better predictive biomarkers than what we're working with right now.
Not that we're suggesting anything to the current authors that we are looking for, but I do think there is some data coming our way.
Well, here's the question, actually.
Oh, go ahead, Mihir. Yeah.
What do you do in the setting where the CPS on the biopsy is less than 1, but on the resection for someone who would qualify then is greater than 1? What do we think about that in the adjuvant setting? And how do we approach that?
I guess the first question is, are you testing everybody routinely? And what level of discordance are we expecting here?
Well, I mean, it kind of boils down to the difference between a biopsy and then surgical resection, right? Mm-hmm. And then where you may have a little more information. And then the second question is do we course correct, or do we add immunotherapy at that point when they didn't get it up front?
I think we could add to that the people who were like, no, doc, I just need you to take it out of me. I want to go to the OR right now. Post-op. So what was that you were saying about the immunotherapy? Could you do that now? So there's an aspect of, have we learned something new about the patient's biology, or has the patient now reconsidered? And is there any other situation where we would want to add the adjuvant? That's 15 doses that we could get them. I do think that there's a role for that, because the addition of that adjuvant is not predicated on the response to the neoadjuvant. And if you're talking about that much of the Keynote 689 treatment still being available to them, I would be willing.
Yeah, Jen, and to your point, I think we shouldn't forget about the Nevo post-op study. And so as we're within our groups discussing how to operationalize 689, this other study needs to be also part of that discussion, because there are going to be patients, whether we're treating them primarily, who, like you said, do not want immune therapy up front, or maybe they come to us on the back end after surgery and we're helping with their management. We have this really rich data. I think we need more information from that trial as well, but there are elements that we can incorporate into practice.
Yeah. I have further problems with okay, so we already got through the neoadjuvant period. You've gotten to the operative period. You've gotten your chemo-BMO. What about after that? Still 12 doses to go, friends. What if the patient was to consider in that situation? How much of that benefit could you still get them with those additional 12 doses that you've got sitting there for you? This is not the way that the trial was written, but this is the real life questions that we're going to see a little bit more as we adopt this and as we see the variety of patient journeys that we are all, getting to see within our clinics. And I'll admit, I'm posing that I don't have an answer.
A biomarker would be great.
Well, could you go to Q6 dosing with 400? I mean, that's the other question. I don't think it's unreasonable, but I'm asking you all because I don't deliver the medication.
Yeah, I'll just editorialize and just say, as it relates to the paper, it was 200 every 3 weeks. That being said, now the real world, obviously, those are considerations that I'd leave to my colleagues, but for the purpose of the paper statement, that's how it was written.
Chair time matters. There is subcutaneous administration, Q6 administration. These are the very thoughtful attempts from these drug makers to be able to give our patients back time when this cancer is trying to rob them of it. And any way that we can facilitate that, I am here for it, as long as we do the PK/PD data and we show that there's no decrease in efficacy and no increase in toxicity. And I think we've certainly seen that with the pembrolizumab. They've done the work. I'd be all for 6-week regimens.
All right. Well, I think this brings us a little bit full circle. We've kind of covered the neoadjuvant. We've covered a little bit about what toxicity looks like and how to think through that, about what tumor progression looks like. We've certainly, hopefully, you as a listener and viewer here have seen just our really strong encouragement to make this multidisciplinary and not strike out on your own, but really bring in your colleagues together to really talk through it and talk through the emotional reactions to some of these things as well. Our patients deserve it. Any other concluding thoughts or things that you each want to share regarding this rollout?
I would say that my number one piece of advice is pick up the phone. Call your surgical colleagues. Be receptive to when they are calling you. We can talk about operationalizing this, and we should talk about operationalizing this at a university level, at a practice level, but nothing is ever going to replace a good conversation when you call the phone and you get Adam and you say, I'm scared.
Yeah.
We got to talk.
I also think I feel like head and neck cancer is very unique in the way, not even just the way, but the providers and the number of people that are involved to help care for these patients, from a number of people you mentioned, but not just that, but also speech therapy. We're talking about a huge team to help these patients. And I think all of us kind of notice that when we go to the Multi-D conference, and we realize that we kind of know each other's across specialties. We know each other because we're integrated in so many ways and pathways. And this is just adding another layer of integration. So I think that's a big part of it, is really understanding who and how and what we're all contributing together, and that we're working in the best way we can for the patients. And now that we have another layer to add, it's like Jen's saying, we got to communicate. We got to level our messaging and playing field so that we can really get patients through the door and through this process.
Yeah, no, I agree with Jen and Mihir. I'd say for future directions, I think this is really opening the door for something that's even more exciting for us as a field and for our patients. And so having immune therapy as a treatment option in the neoadjuvant perioperative setting now will allow us to push the needle further. And I think we're going to have more discussions about how to optimize the timing of the care and what we can add or subtract from our treatment. So this is a really exciting time for the field.
Awesome. Well, thank you all for being here. Listeners, thanks for joining us today. And we look forward to our continued effort to improve the lives of all those we care for.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe Legrizio,
Josh Spencer,
and Jaden White.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
See you next time.